Reduction of maternal mortality, a key millennium development goal, is slow in most of the countries, and especially in the country, low socioeconomic countries and developing countries like India. The crisis for developing as well as developed country was maternal mortality ratio, but in developed countries where number of maternal deaths have decreased, to tell about their health condition, they have started talking about SAM, that is severe acute maternal morbidity, because there are very rare maternal mortalities. But in India, we have got, of course, for the auditing of what our health services are, we also need to know what exactly near miss or severe acute maternal morbidity is, because there, if we intervene at right time, we can prevent maternal mortality. So here comes the need to know about near miss. The life of a woman is not easy. She not only has to take care of herself, but of everyone she knows. Tragedies are always in her path, and it's our responsibility to give her a safe motherhood. Pregnancy is a physiological phenomenon. It's our duty as an obstetrician to give her a safe motherhood. Not only the obstetrician, but a multidisciplinary approach, so that all of us can join together, take care of severe maternal complications and decrease the rate of maternal mortality. Rudyard Kipling has said very nicely that I keep 6 honest serving men, they taught me all I knew. Their names are what, by, when, how, where and who. So we have to know that what we know about maternal morbidity, what is its important, why it is important to know, and let's look for the answers. Maternal mortality is just the tip of the iceberg. It has got a very vast base, which is maternal morbidity, which is undescribed and undiscovered. A maternal near miss case is a woman who nearly died but survived a complication that occurred during pregnancy, childbirth, within 42 days of termination of pregnancy. In practical terms, women are considered near miss cases where they survive life-threatening condition, that is organ dysfunction. Now I would like here to tell something, that when a patient suffers a complication, it starts with morbidity. Then it turns into severe complication. Severe complication leads to organ dysfunction. Organ dysfunction is the condition where we call it as near miss. So a patient who has suffered from severe maternal complication can have two outcomes. Either she can be lucky enough to be near miss, that is missing the death, and or she can die. Why we are using near miss term? Because in fact this term has been borrowed from air industries, where they call it as near miss when two aircrafts are in the air and they, by their risk management, they stop their collision. Here it is not like that, because here the morbidity has to be suffered by the patient. There is no suffering. The planes are separate together. They have been taken care. Here we mean near miss if we want to compare with them, like there is a blood group O positive. It has been labeled wrongly as A positive. And when all of a sudden we see, oh okay, this is O positive, A positive blood group, and we are going to transfuse it to a O positive woman, then it is a near miss. Means patient has not suffered the consequences of wrong blood transfusion and it has been saved. So this is a part of near miss which is comparable to air industry. But here WHO has now come with a near miss approach. So that there is a difference in term of severe acute maternal morbidity and near miss, but we are using near miss as a near miss approach, whereas the exact terminology is severe acute maternal morbidity. Why it is important? Why we are so bothered about knowing about near miss? That's what I discussed before, that 2 decades ago in low maternal mortality settings, morbidity is usual indicator of obstetric care. But in recent years, analyzing near miss or SAM cases helps us in understanding health system failures, why we are not able to decrease our maternal mortality, why we are not able to take care of those severe complications which can have two outcomes, either near miss or death. Why can't we prevent that death? So for us, near miss is important to know and identify those severe maternal complications which can be prevented or timely managed at a healthcare system. Near miss cases occur more often than maternal death and may generate more information because the woman herself can be source of data that what problem she suffered. Once she dies, she dies. She cannot tell ki I had this problem. If it would have been taken care at proper time, I would have been saved. So here the woman is alive. Once severe maternal morbidity precedes maternal death, the systematic identification and the study of near miss cases may provide further understanding of the determinants of maternal mortality. Like in our area, suppose an area where malaria is endemic. So that local area knows that my patients are suffering, my maternal deaths are more because of suffering of malaria. So they are geared up in taking care of malaria. So we have to find out our own ways to identify that particular area's severe morbidity and take care and availability of the facilities for that particular disease. So this has to be locally identified in your area that what are the causes and has to be taken care of. We all know 5th Millennium Development Goals. Now, if we talk of maternal morbidity, I said that near miss starts from organ dysfunction, then it comes to organ failure and death. Suppose a patient is there of anemia. If at the right time, either the ambulance is not available to make her reach to the health facility center, or if she has reached and blood is not available, she will go uphill. From clinical problem, a simple problem of anemia, a maternal complication of anemia, if she is not given blood in time or not provided the facility, she goes uphill. There is an organ dysfunction, there is an organ failure and death. But if at this point, at the point of this complication, she receives blood in time, care in time, there is a downhill and she delivers a normal baby. So we have to know about these severe maternal complications and near miss cases. We have to treat and manage them, then only we can reduce our maternal morbidity and mortality. Again, anticipate, react to illness will help us in reducing maternal mortality. Identifying common predictive factors, more effective preventive strategies like anemia, infection, hemorrhage. Timely treatment of postpartum hemorrhage will save a patient from maternal death. How to identify cases of near miss maternal morbidity? There have been so many criteria. In old times there were Waterstone's criteria, Mendel's criteria, but now WHO has come with WHO near miss approach, where they say that any severe acute morbidity or complication can lead into severe maternal outcome, which can be a near miss or maternal death. What is a severe maternal complication? Now we have to understand what are the conditions which we have to label as severe maternal complications. These are potentially life-threatening conditions. This is an extensive category of clinical conditions, including diseases that can threaten a woman's life during pregnancy, labor, and termination of pregnancy. Here we count 6 diseases, 6 conditions: severe postpartum hemorrhage, severe preeclampsia, eclampsia, sepsis or severe systemic infection, ruptured uterus, and severe complications of abortion. These all come first. We categorize, yes, this woman is now eligible to be labeled as severe maternal complication. So according to WHO approach, these are the criteria clinical condition wise. One is management wise. If the patient for any condition is admitted into ICU, or if there is any interventional radiology is required, there is a laparotomy is needed, includes hysterectomy, excludes cesarean section, or if there is use of blood products. All these things, they come into severe maternal complications. Severe maternal complications are potentially life-threatening condition. Next step is life-threatening condition. So any patient who directly presents as a life-threatening condition, like any of the organ dysfunction, cardiovascular dysfunction, respiratory dysfunction, renal dysfunction, coagulation, hematological dysfunction, hepatic dysfunction, neurological and uterine dysfunction is again labeled as severe maternal complication. So I have told you 3 criteria of severe maternal complication. One is clinical condition, another is management wise, that is admission to ICU requiring intensive intervention radiology or requiring laparotomy, and third is organ function based criteria, and these are the life threatening conditions. Severe maternal outcome is either a maternal death or a near miss, and women with life threatening conditions are the addition of maternal near miss and maternal deaths. As per WHO study, in resource poor setting like India, 4 to 8% of pregnant women who deliver in the hospital will experience SAM. So we have to be prepared to prevent and manage these cases of severe acute maternal morbidity. As Madam said, that 15% are likely to suffer the maternal complication, and after that 5% are going to suffer the severe maternal complication. So we do not know. Of course, there are risk factors by which we identify. But when scenario changes, we are not able to know, so we have to be prepared for all type of complications. Prevalence of SAM is higher in studies conducted in less developed country settings. So risk management, we have to take care of all the conditions where there is a risk, and we have to cut down our risk rate. Here it comes to whatever we are doing, whether we are doing grouping, cross-matching, cesarean. Suppose you give a wrong prescription in a maternity ward. Prescription belongs to A and treatment is given to B. So that is again a risk management. So we have to take care of all these small things to avoid any such disaster. And last of all, but not least, this high dependency unit. Every institution has to have a HDU. It is separate from ICU. It has got its own advantages. Obstetric HDU is highly specialized and discrete area within the delivery suite labor room for SAM with best facility. And team that was initially treating them. It is not a new team. Whatever we are treating the same patient in HDU also. So this is the advantage of having an obstetric HDU. Early intervention and specialized treatment can prevent serious complications and avoid hazards of transfer to patient to ICU in a separate location. It is there in your labor ward. So you can immediately transfer the patient with the slightest of suspicion. Antenatal, intranatal and postnatal care can be provided by the same team. Early intervention and specialized treatment. HDU may avoid exposure of critically ill pregnant patients to hazardous ICU environment with the risk of hospital acquired infection, because there is no intermingling of these patients with other patients. It is a need of most tertiary care centers. Conclusions are: reviewing cases of severe maternal morbidity can provide useful complementary insight into quality of care. A good quality medical system is required for all of us, because we have promised to take care of a pregnant woman. It should not be like Tom and Jerry. Tom is like morbidity and mortality, and Jerry is the mother. So it should always be, Tom should be chasing Jerry and he should never be able to catch hold of the mother. I'll show you a small UNICEF video which will give us